Hello, our Pico group presentation was based on the effect of caregivers on CVA patients. Our group members consist of Ariana, Jessica, Amanda, Fanon, and Oliver. We chose a clinical question of, does the presence of caregivers of CVA patients affect the CVA patient's physical well-being? We thought it would be an interesting topic to go into because this research primarily focused more on the impact that caregivers have on patients' recovery versus other researchers that just focuses on the patients. We'll be going into the method presented by Jessica next.
So some of the resources we used to conduct this study is SINAHL, PubMed, Cochrane Library. Some keywords we used were stroke recovery, caregiver, external stressors, and well-being. Some strategies we used to do it was narrow search based on findings. And by this, we found 5 articles relating to this topic. Next, we're going to go over a review of the literature.
Our levels of evidence varied depending on the study. Of the 5 studies, 3 of them were cohort studies, which display a level 4 evidence. One study was a case-controlled study that displayed a level of 4 evidence as well. The last study was a randomized quasi-experimental study, which displayed a level 2 evidence. The settings of these studies were also varied. 3 of the studies were done in Singapore, 1 in Thailand, and 1 in Italy. The sample sizes of the studies ranged from 164 participants to 593 participants, including both the caregiver and the stroke survivor. All the studies involved informal caregivers, which are caregivers that have no training, such as family members. One study included formal care, which are trained healthcare professionals. Sample characteristics were gathered from both stroke survivors and their caregivers. All the studies showed that the majority of caregivers were spouses of the stroke survivors, at a little over 50%. The studies also showed that the children of the stroke survivors were the second most popular type of caregiver, at roughly 30%. Other options for caregivers that were included were siblings and others. Additionally, the majority of caregivers were females that ranged from 50 to 76 years in age. This contrasted the stroke survivors, who were mostly male and between the ages of 62 and 76. 4 of the 5 studies showed that stroke survivors had specifically ischemic strokes. The last study didn't identify the type of stroke. 4 of the 5 studies showed that the majority of post-stroke participants had comorbidities such as hypertension. These studies used a few similar methods to measure the differences between stroke survivors. Of the 5 studies, 3 of them measured for depressive symptoms of the stroke survivor using the Center of Epidemiologic Studies Depression Scale. Of the 2 studies measured for, 2 of the studies measured for health-related quality of life. One study measured for improvement of daily functioning by using the World Health Organization Quality of Life Scale. 5 of the 3 studies used the Barthol Index to measure the stroke survivors' dependence, showing that most of them were of slight to moderate dependence. 4 studies used the Modified Rankin Scale to rate the level of stroke survivors' disabilities, which showed that the majority of those tested were of moderate disability. 2 of the studies used the mini mental state exam, which showed that most of the patients studied had no to mild cognitive impairment. Of all the studies began after the patients were discharged from the hospital. 3 of the 5 studies involved telephone interviews, 1 involved a questionnaire, and 1 involved face-to-face meetings throughout the study. Next, we have the synthesis of findings.
In the findings, we noticed that formal care is more effective than informal care. These research articles also showed that a caregiver's role has significant outcome on the recovery of a CVA patient. Certain studies showed that by focusing on preparing the caregiver and coping mechanism, it will benefit the CVA patient in the long run with recovery. Other studies also showed that a survivor's path after a stroke was associated with the caregiver's burden, anxiety, and depression. Those in particular survivors slightly worsened during the recovery process, and their caregivers needed more attention and help because they were at risk for more serious outcomes. The post-stroke care program improved family caregivers' post-stroke care skills, which helped result in improved functional status, and it helped decrease the complications among the recovery process with the post-stroke patients. This program focused mainly on the caregiver's knowledge on the care they were providing, physically demonstrating how to perform the care, and improving their caregiver's confidence while performing care for the CVA patients. Overall, the outcome of all these on focusing on the caregiver's role were positive. It showed that CVA patients with caregivers had a reduced chance of being hospitalized than those without caregivers. It also showed that by focusing on caregivers' skills, knowledge, and well-being, the CVA patient was able to recover with minimal complications during the recovery process, and eventually were able to perform their ADLs independently with minimal assistance. Now we'll be talking about the decision of practice, and Ariana will be going more into that. Next, we'll be going into decision about practice.
We found that current research suggests that there is a direct correlation between caregiver relationship and post-stroke outcomes. Patients with caregivers who experience minimal caregiver burden have a lower rate of rehospitalization within the first year of post-stroke recovery. This proves that the presence of a caregiver has a positive effect on the physical well-being of CVA patients. In regards to implementation, we found that the most effective way to implement the presence of a caregiver is to reduce caregiver burden. Post-stroke patients with informal caregivers develop significantly greater depressive symptoms. As previously mentioned, research defines informal caregivers as unpaid personnel without any prior training or licensure for caregiving. Informal caregivers are usually spouses, siblings, children, or even close friends, also previously mentioned. This proves that not only does the presence of a caregiver affect the well-being of the CVA patient, but so does the quality of life of the caregiving individual. Meaning, if the caregiver is happy, content, and prepared for their new role, the post-stroke patient will most likely experience a smoother recovery. We found that the best way to encourage caregiver presence is with implementation such as support groups. Support groups provide a social support to reduce feelings of anxiety, loneliness, and isolation. Sharing one's feelings about the caregiving experience with other caregivers can be extremely therapeutic and reduce fatigue. Family education is another effective implementation. Whether it's in the form of training or skills classes, family education significantly improves post-stroke care knowledge. This also enables the caregiver to feel prepared for their role and reduce fatigue. Follow-up visits are another effective tool in encouraging caregiver presence. Follow-up visits help reevaluate the patient's condition and reassess needs. It also keeps the healthcare team current on the patient's recovery and allows for an opportunity for caregiver advisement as needed. As the patient's condition changes, the caregiver may have different questions along the road to recovery. Answering these questions benefits the patients to ensure they are receiving the best care, as well as reducing care burden. Lastly, role strain testing is the most direct way to assess caregiver burden. As we've proved and mentioned, caregiver burden is the biggest adversary to caregiver presence. Addressing caregiver role strain introduces opportunities for relief when needed to ensure that the post-stroke patient will have a consistent caregiver present to improve recovery, because it keeps the caregiver from being burned out and leaving their role. Caregiver relief can come in the form of respite care or just having someone come over informally and helping out with the caregiving. The primary goal of these implementations is to support the caregiver and reduce caregiver burden and fatigue. Keeping the caregiver energized, educated, and happy is the best way to encourage caregiver presence for a smooth post-stroke recovery. Next, we'll go over the evaluation of our studies.
So for evaluation, we said assess post-stroke patients every 6 months for rehospitalization, functional outcomes, and depressive symptoms. We know what we implemented is worth it because this highlights the role of caregivers and whether they are still a beneficial asset to post-stroke patients. What we also implemented that will be worth it is that it gives us insight whether these patients are improving or not. Some of the outcomes we want to look at are rehospitalization after post-stroke. We want to figure out if these individuals are going back in. If so, how often and why. We want to see if they're coming into the hospital for stroke-related factors. Another outcome is cost trajectories or cost estimates. We want to see how these type of situations are affecting them financially. The association with caregivers is another important outcome because this focuses on the role of caregivers and the association of recovery for these patients. We want to see if there are any changes, such as not having a caregiver anymore, or some may have transitioned to a spouse or family caregiver to a non-related individual. We want to look at functional outcomes and depressive symptoms as well. We want to see if there are any improvements over time, and we can be able to compare this type of data to baseline data from when they first suffered through this. This is another factor that can support the importance of caregivers as they are one of the contributions to the patient's improvements. We also want to look for the caregivers in regards to caregiver role strain, as this heavily affects patient recovery. For someone who suffered from a stroke, the role of caregivers are essential as they are being assisted. Therefore, caregiver role strain can affect how these patients will fulfill their needs. And the longer this strain occurs, this can overall affect the patient's health in the long term drastically and dramatically. We would measure these outcomes every 6 months by looking at data and possibly being in contact with these patients to gain more insight on how they're doing, their relationship with their caregivers, and most importantly, their thoughts and feelings. We think that measuring these outcomes every 6 months can still give us an accurate insight to the study we have conducted. And now we are going to discuss about discussion.
So for the discussion, we agreed that giving the caregiver support and identification of caregiver role strain will help better the quality of life of the patient during recovery. So legitimating clients with their own needs as advocates for their recipients helps to acknowledge the balance the competing commitments caregiver burden introduces that are strongly associated with the rehospitalization of stroke patients. In all the articles, the evidence pointed that that the having a caregiver there was beneficial, but what was really more pointed out was the fact that caregiver role strain can also take a toll on a patient's recovery. If the caregiver is suffering from depression and anxiety, it could negatively affect the patient. That is why there is an offering of support groups to help the caregiver with these types of problems and to also benefit not just the caregiver, but also the patient. It is important to remember that the caregivers are also human beings and they are living their own lives while also taking care of another person's life and helping them with daily tasks and all sorts of things that the stroke patients can't do on their own. So, by having all of this evidence present, it is evident to us that having a caregiver there can positively affect a stroke victim's quality of life while they are recovering from a stroke. But if the caregiver is suffering from anything like depression and anxiety, it could also negatively affect the patient's recovery and their quality of life. So to wrap things up, this is our study conducted on CVA patients and their care in correlation with their caregivers and their recovery. Thank you for listening.